and our eminent speaker. I am Siddharth from Zydus Medica, honored to welcome all of you to this scientific digital platform called CLEARTalk. On behalf of Zydus Life Sciences, I would like to express my most sincere gratitude for your presence in this scientific webinar. Giving you all a small brief about CLEARTalk. CLEARTalk is one more initiative of Zydus, which encompasses one more facet of Unite Against Dyslipidemia. As you know, in India, 1.25 crore population are having uncontrolled LDLC, which increases cardiovascular risk. And for that, recent development in the field of management of dyslipidemia brings you bempedoic acid as an add-on choice for LDLC management. Hence, this season of CLEARTalk is focused on one more development that pharma and medical fraternity are witnessing. That is late-breaking clear outcomes trial presented in the ACC 2023. The program is based on our objective of increasing awareness about the usage of bempedoic acid for all practicing physicians and general practitioners. It is basically to upgrade the knowledge on the late-breaking CVOT trial and the management of LDLC and dyslipidemia. Well, to take this program ahead, we have our eminent speaker, Dr. George Koshy. Talking about our eminent faculty, our eminent speaker today, George Koshy. He is a senior consultant cardiologist in Cosmopolitan Hospital, Trivandrum. He was a former professor and head of cardiology at Government Medical College, Trivandrum. Former director of Kerala Heart Foundation. His field of interest includes echocardiography and coronary interventions. 72 publications in national and international journals he has got. He has been former president of Kerala chapters of CSI, Indian Academy of Cardiography, and Indian College of Cardiology. So with this, I would request Dr. George Koshy to start with today's program.
Thank you, Siddharth, for your nice introduction. Let me share my slides. Just a minute.
Sure, sir.
Can you stop sharing your slide?
Done.
Okay, thank you. My slides are visible?
Yes, sir. You may just start the slide.
Okay, I will go to the slideshow. Okay, right. Good evening. My talk today is primarily on bempedoic acid in statin intolerance, with statin and beyond statin. Let us see what exactly is the role of bempedoic acid in the current lipid scenario. There's a very strong relation between LDL cholesterol and CAD risk. This is what we call as the 30-30 rule, which we discuss very often. There's a 30% reduction in LDL that leads to 30% reduction in CAD, irrespective of the initial LDL level. If your initial LDL level is 190, and if there is a 30% reduction, you bring it down to 160, you have a 30% reduction in CAD. Then 160 to 130, again the same thing happened. 130 to 100, again the same thing happened. So it's a very, very consistent relation. And LDL lowering with statin for 5 years, how much is the reduction in MACE? So if you give statin for 5 years, you reduce the LDL cholesterol by 40 milligram, you have a relative risk reduction of 20%. This is true for both secondary prevention and primary prevention. But the benefit is more when you are dealing with secondary prevention, basically because the major cardiovascular events are more when it comes to secondary prevention compared to primary prevention. And if you reduce the LDL by 80 milligram, you get a relative risk reduction of 40%. LDL reduction of 120 milligram, you get 60% relative risk reduction. So this is a very, very consistent observation. And this concept is something we should very clearly understand. The concept of cumulative LDL cholesterol burden. It is not only the level of LDL cholesterol which is important, but how long it remains elevated. So the duration and the quantity both are important. And we tell that the threshold for developing CAD is something like 6,000 milligram years, meaning that if a person has an LDL cholesterol of, say, 100 milligram, over a span of 60 years, reaches 6,000 milligram years. But if your cholesterol is much higher than that, you reach this threshold much earlier. For example, someone with 200 milligram of LDL cholesterol will be reaching this threshold in 30 years' time. But if your LDL is very low, say it is just 60 milligram, you will be reaching this threshold only after 100 years. So chances are that you may not develop an acute coronary syndrome during your lifetime. This is a very, very simplified thing, but it is a good concept. For example, let us take familial hypercholesterolemia, in which the LDL is something like 400, 500 milligram and all that. You reach the threshold in 10 years' time. They develop MI and die by the age of 10 years. Heterozygous FH, the LDL value may be 200 or 250. So you reach the threshold in 25 years or 30 years. And this threshold is modified by other risk factors. If you have smoking, hypertension, diabetes, and risk factors like that, the 6,000 milligram years may come down to 5,000 or 4,000. So the point is, the LDL level is important, and how long it remains elevated is equally important. So we have to intervene early. That is the message. Now, each 1 millimole per liter reduction of LDL, 1 millimole is something like 38.67 milligram. So much of reduction in LDL gives more cardiovascular events reduction according to the number of years in the various trials and comorbid conditions as well. So those are the two important variables. How long you kept the LDL low, and number two, which are the comorbid conditions. For example, if the patient was in a lipid trial for 1 year, the reduction in the event rate will be just 11%. But the LDL lowering for 2 years, the reduction is double, 24%. The LDL kept low for 3 to 5 years, the percentage reduction in risk is 33%. Now, beyond 6 years, it increases to 36%, and then it levels off. Similarly, depending upon the comorbid condition, that is what is shown lower down, the benefit is variable. The maximum benefit is in people with cardiovascular disease and diabetes. They derive the maximum benefit. And if you lower the LDL by, say, 5 millimole, meaning something like, say, 180 milligram. The percentage reduction is something like 62%, very high. Whereas if you take an individual, no cardiovascular disease, no diabetes, the LDL reduction is just 1 millimole, meaning around 40 milligram. The reduction in the event rate is just 2%. And this is another very, very important concept. We always tell the medical students that as long as the LDL remains inside the blood stream, not getting into the vessel wall, there's no big issue. Even if your LDL is 200 milligram, if it remains inside the vessel, it's okay. But the problem is it gets into the vessel wall. It gets into the vessel wall, not in everyone, in some people. They are the people who are developing atherosclerosis. And it's a very long-drawn process starting from childhood. We know the fatty streaks, the fibrous plaque, the plaque progression, and then the plaque becomes unstable, then the person develops an acute coronary syndrome because of the activation of the platelet anticoagulation cascade. That is a natural history of coronary artery disease. So you have a phase when you have no atherosclerosis in early childhood, then you have the plaque building up slowly, and then you develop an event. When you develop an event, then you know the attention changes. Then people say, okay, he has developed an MI. He is a post-MI patient. Then everyone starts speaking about secondary prevention. But what about the previous year? Even at that time, he had significant plaque. But you thought that he does not qualify for any aggressive treatment because it is just primary prevention. So we should understand that the line between primary prevention and secondary prevention is very thin line. That is why, you take diabetic people. They might not have had an acute coronary syndrome. They do not have evidence of, any coronary event or stroke or peripheral arterial disease or anything like that. But that does not mean that they do not have atherosclerosis. So the point is, one should be able to detect atherosclerosis in the subclinical phase and then be more aggressive with lipid management. That is my point. So just because someone did not develop a heart attack or a stroke does not mean that he does not have significant atherosclerotic plaque burden. Unless you start investigating, you may not pick it up. So a completely healthy person undergoing a treadmill positive, you immediately, your primary prevention changes to secondary prevention. You do a carotid intima media thickness, CIMT, positive, immediately your primary prevention becomes secondary prevention. You do a CT coronary angiogram showing some plaque, immediately primary prevention becomes secondary prevention. You do an ankle brachial index, abnormal, primary prevention becomes secondary prevention. So though we tell about primary prevention and secondary prevention, and we have different criteria, please do understand this is a continuum. And you should always think that people whom you think there's no atherosclerosis could be having significant atherosclerotic burden. And another important point, when you use statin, please do understand that small dose of statins are very good. For example, atorvastatin 5 milligram reduces LDL by 27%. You double the dose, 10 milligram. How much is the LDL reduction? Another just 6%. You double it, 10 becomes 20 milligram at atorvastatin. How much is the LDL reduction? Just another 6%. So between 5 milligram and 80 milligram atorvastatin, the LDL reduction is 27% and 51%, not even double. So small dose of statins are very effective in reducing LDL cholesterol, whether it is rosuvastatin or atorvastatin. And along with that, the statins and the other lipid-lowering agents, including bempedoic acid, have significant pleiotropic effect. And if you look at the ESC guideline, we have the different, threshold. The low risk, moderate risk, high risk, and very high risk. And remember, people with very high risk, they are people with significant atherosclerotic cardiovascular disease or multiple risk factors, diabetes with target organ damage, and things like that. Very high likelihood of severe disease. In such people, the threshold for LDL is 55 milligram. So you lower the LDL below 55 milligram. This is a change from the ESC 2016. So over a span of 3 years, the threshold have come down. So moderate risk 115 has become 100. High risk 100 has become 70. At very high risk 70 has become 55. But what about the Indian scenario? This is the Lipid Association of India guideline. We have a special category. Look at that. The extreme risk category, category A and category B. What is that category B? They are people with CAD, very high risk group, people who develop acute coronary syndrome within 1 year, despite significant LDL lowering below 50 milligram, or polyvascular disease. We do come across such people. Young man, anterior LMI, on maximum dose of statin, LDL 45. He is again coming with an acute coronary syndrome after 6 months. So what can you do for such people? So this is the current recommendation. High intensity statin. If the LDL level is more than 50 milligram, you add ezetimibe. If the LDL level is still more than 50 milligram, you add bempedoic acid as the third agent. Third add-on drug is bempedoic acid. Or you can use evolocumab or a PCSK9 inhibitor like alirocumab. And what is the LDL goal? In the Indian population, the Lipid Association guideline, category A, you aim at LDL below 50 milligram. But that extremely risk category, you can even aim at an LDL below 30 milligram. So quarter century of treating LDL cholesterol, we have brought down the threshold from 120 milligram to as low as something like 40 or even 30 milligram. It is not only the LDL level, but the duration is also important. So start treating it from a young age. So management of dyslipidemia is high on the priority. No doubt about that. If you want to prevent the LDL getting into the vessel wall, the most important thing is to keep the LDL low. Along with that, you should optimally treat the hypertension, diabetes, give up smoking, and all lifestyle modifications. But primarily, you have to keep the LDL low. But you have two important concerns. Number one, do all statin users achieve the LDL goal, which we mentioned just now, as per the guideline recommendation? And concern two, how to achieve the LDL target after maximally tolerated dose of statin. And based on the revised ESC 2019 guideline, which I showed just now, how many patients do have controlled LDL? That's very interesting. And we have a trial, the European Union, the wide cross-sectional observational study. It's not a trial, it's an observational study of lipid modifying therapy used in secondary and primary care, the Da Vinci study. Number of patients around 6,000, 3,000 primary prevention, 2,888 secondary prevention. So this is what they found. As per the revised guideline from the ESC, 27.6% eligible patients are receiving high-intensity statin. How many are reaching the target? Just 30%. So only 30% are reaching the target. If you take the entire patients, if you take the very high risk patients, is it different? 37.5% eligible patients are receiving high intensity statin. So that is slightly better. But how many are reaching the LDL goal? Just 22%. Meaning 78% of the very high risk patients are not reaching the LDL goal. Currently, based on the ESC guideline, if you use the Lipid Association of India guideline, it may be even less, maybe something like 15% or 18%. So what can we do? Statins alone are not enough. We require add-on treatment. As I mentioned, ezetimibe is the second add-on drug, and the third add-on drug currently is bempedoic acid. Because PCSK9 inhibitor is a good third add-on drug, but it is very expensive and in the Indian context may not be very practical. We should have an idea how much of LDL lowering really happened with our pharmacological treatment. Moderate intensity statin, 30%. High intensity statin, it becomes 50%. If you combine high intensity statin with ezetimibe, for example, 40 milligram rosuvastatin with 10 milligram of ezetimibe, you reduce the LDL by 65%. Evolocumab, PCSK9 inhibitor alone, 60%. PCSK9 inhibitor with statin, 75%. Now PCSK9 inhibitor with high intensity statin with ezetimibe, you can reduce the LDL up to 85%. This is 2019 European guideline. Bempedoic acid was not available at that time. Only after that, it got the clearance of the EMA as well as the FDA. And if you use ezetimibe instead of PCSK9 inhibitor, we may not be able to achieve the same degree of LDL reduction, but significant reduction in the LDL is possible. To what extent, I will come shortly. Now, before I go to the bempedoic acid per se, this is a recent trial, the Lancet 2021, trying to find out whether high-intensity statin is better or lesser dose of statin with a non-statin trial. This is a racing trial, 7-year follow. They found that simvastatin, lower dose with ezetimibe, is as good or better than high-intensity statin. So this is a new concept. This is not only with ezetimibe, it is true with bempedoic acid also. So we have to look into that. Rather than 80 milligram atorvastatin, which many people may not tolerate, we have an option of 10 or 20 milligram of atorvastatin with ezetimibe or bempedoic acid. Or maybe even 10 milligram atorvastatin with 10 milligram ezetimibe with 180 milligram bempedoic acid. That's a new concept which is coming up. So this is the molecule which we are discussing today. Bempedoic acid, it inhibits the ACL enzyme that is upstream to the HMG-CoA reductase, which is inhibited by the statin. The most important point is that skeletal muscle side effects are very uncommon with bempedoic acid because the enzyme is not present inside the muscle. So the skeletal muscle side effects, myalgia, myositis, those things are significantly less. But hepatic side effects can occur with bempedoic acid also. And these were the previous trials. 2 groups of trials were available. One as an add-on treatment because people cannot reach the LDL goal. Maximally tolerated statin background therapy, that is a blue thing. The Clear Harmony, 2,230 patients. Most of them having atherosclerotic cardiovascular disease, 98%. And the clear wisdom, 779 patients. This is one group. The other group is that orange one. That is people who cannot be given statin intolerance, or very low dose of statin, background therapy. That is a clear serenity or the clear tranquility, 2 trials. But look at that, the numbers are very small, 345 and 269. So it is at that time, these were the concerns and the observations. LDL reduction with bempedoic acid without statin is 24%. Remember that. So how much of LDL reduction you get with bempedoic acid without statin? It is 24%. With statin, what is the additional benefit? 17%. So this is almost similar to statin with ezetimibe. Now, bempedoic acid with ezetimibe, 38% reduction. So that is reasonably good. Now, they had 4 important concerns about the side effects of bempedoic acid. One was the issue of tendon rupture, which in some of the studies they found 1 in 200. Increase in the uric acid was observed. Gout was observed in 1.5% versus 0.4% in the placebo. They thought that there could be a little more of atrial fibrillation, some increase in the CK. These were the concerns with the earlier trials of bempedoic acid. And this was the information we had. Half-life long, 21 hours. Elimination, 70% excretion of the total dose is through the kidney. 5% excretion through the feces. Less than 2% excretion of the unchanged drug through the kidney. So renal impairment and hepatic impairment, we need not worry regarding bempedoic acid unless it is very severe. In people with end-stage renal disease and severe hepatic impairment, you do not use that. Otherwise, there is no need for any dosage adjustment. What all things should you monitor when a patient is on bempedoic acid? You should certainly monitor the uric acid, because people can have increase in uric acid and sometimes gout, especially with the people with the history of gout. But gout, I don't think, is very common in our country. And special care in people above the age of 60 years, taking corticosteroid or fluoroquinolones, and people with renal failure and a history of tendon rupture, because tendon rupture is something which we should always look for. But the recent trial has not highlighted that, but in the earlier trial, people looked into that side effect. Now, people more than 60 years of age taking corticosteroids or fluoroquinolones with renal failure and a history of tendon rupture, you should be careful, and we should discontinue the drug if tendon rupture occurs, and consider discontinuing if joint pain, swelling, or joint inflammation occurs in the patient. And another point, do not combine bempedoic acid with simvastatin and pravastatin. And fortunately, these statins are not used now. We use mainly atorvastatin and rosuvastatin, for which there's no issue. And pregnancy and breastfeeding are contraindication for any new drug. Now, bempedoic acid through the lenses of the clear outcome trial. Let us see what were the observations. This was the background. There are a lot of people with statin intolerance, roughly around 15%. And some people are not really intolerant, but they refuse to take statin. They don't want to take statin. So statin intolerance. So what can we do? We have bempedoic acid, ATP, citrate, lyase inhibitor, not present in the muscle. So muscle side effects are very uncommon. Now, till this outcome trial came, we did not have any idea whether bempedoic acid will really reduce the event rate. Bempedoic acid was approved for lowering of the LDL cholesterol, both by the FDA as well as by the EMA. And now we have the cardiovascular outcome trial. the cardiovascular outcome assessment. And this is that trial, the CLEAR outcome trial, published in NEJM 2 weeks ago. The cholesterol lowering via bempedoic acid and ACL inhibiting regimen. Late breaking clinical trial presented in ACC 2023. So this included patients with cardiovascular disease or at high risk for cardiovascular disease. So both secondary prevention, that is CVD, and high risk of cardiovascular disease, that is primary prevention. Just I mentioned earlier, the demarcation between primary prevention and secondary prevention is not as strong as many people think. Because what you think as primary prevention may ultimately turn out to be secondary prevention if you start investigating that patient. And they took people who had an LDL more than 100 milligram. 100 milligram, not too high, more than 100 milligram. And the primary endpoint was a 4-point base. I will come to that. This is the baseline characteristics. Mean age 65 years. The mean LDL cholesterol was only 139. The high sensitivity CRP, which you know is a very important marker of vascular inflammation, it is 2.3 in both the groups. The EGFR, majority of the patients, it is between 60 and 90. That is the real world situation. 20% had in between 30 to 60. They did not take people with GFR below 30 m. Now, in 30% of the people, it was primary prevention. 70% it was secondary prevention because they have evidence of atherosclerotic disease. CAD, majority 51%, PAD in 11%, and stroke, cerebrovascular atherosclerotic disease in 14%. That was the split up. Now, a little less than half were diabetic. So this is actually the split up. Now, the use of ezetimibe was in 11.5% of patients, and statin use was 22.9%. Majority of the people, the statin was very, very small dose of statin because they are all basically people who will not tolerate statin intolerant people. Okay. Now, what about the endpoints? Primary endpoint was the 4-component base. Namely, they looked at 4 things: the composite of non-fatal MI, non-fatal stroke, coronary revascularization, and cardiovascular mortality. This is the 4-point base. Now, the secondary endpoints are shown there. The usual 3-point base, meaning cardiovascular mortality, non-fatal MI, and non-fatal stroke. That is the usual 3-point base. So 3-point base plus coronary revascularization will be the 4-point base. And the other things individually. Those were the secondary endpoints. And what did they find? So bempedoic acid versus placebo. The 4-point base was reduced by 13%. That is shown there. The follow-up available up to almost 5 years. If you take the 3-point base, meaning cardiovascular mortality, non-fatal MI, non-fatal stroke, a relative risk reduction of 15%. Now, fatal or non-fatal MI, 23% risk reduction. And these are all significant. Look at the confidence interval. 4-point base, confidence interval 0.79 to 0.96, 0.87. Look at the p-value. Now, fatal or non-fatal MI, significant confidence interval, coronary revascularization. Each of these things are individually significant statistically with significant p-value. So the effect of trial regimens on the cardiovascular events. So among statin intolerant patients, treatment with bempedoic acid was associated with a lower risk of 4-point MACE of 13%, 3-point MACE of 15%, MI of 23%, and coronary revascularization of 19%. And how much of LDL reduction really happened? That's very important. So a question, how much of LDL reduction happened with 180 milligram of bempedoic acid? This is not on top of statin. Bempedoic acid alone, it is 21.7%. Now, pleiotropic effect. We all tell about statin having pleiotropic effect. The Jupiter trial telling that the HSCRP is reduced by 30%. Ezetimibe also reduces HSCRP. Now, bempedoic acid also has a pleiotropic effect. It reduces HSCRP by 22.2%. So this is very, very important observation. The drug alone, even without statin, reduces LDL by 22% and HSCRP by 22%. Both are 22%. And on top of statin, it is much more, both put together. So this is going to be a very important trend. But we should be concerned about the safety part. Now, what about the safety part? Now, because we have now reasonably good number of patients in this trial, huge number of patients in the trial, which I showed earlier. So the adverse events leading to discontinuation of trial is around 10% in both the myalgia. It is similar to a placebo, 5.6%. Discontinuation due to myalgia, similar to a placebo. Is there any risk of diabetes? There's no risk. One concern with statin is the likelihood of diabetes. Insulin resistance, the HbA1c can go up, and over a span of time, people can develop diabetes. No, the risk is not very high. But here there's no risk. In fact, 16.1% with bempedoic acid, whereas it is more with the placebo. Now, 2 or 3 important concerns. One is renal impairment, 11.5% versus 8.6%. This is something which is being evaluated. Now, change from baseline creatinine level after 6 months. It is not much, just 0.05 milligram per deciliter compared to the placebo. Now, increase in the uric acid occurred in 10.9%. So it is, 1 out of 10. That is something which is important. But in the placebo also it occurred in 5.6%. Gout occurred in 3.1% versus 2.1% in the placebo group. So this is different from the population which we are treating, because we don't find gout that often. In fact, we saw it so infrequently. For example, placebo, they found 2% of the population developing gout. We hardly see a gout. So our population is different. Now, change from baseline. There again, this is something important. The uric acid, 0.76 milligram increase in uric acid, plus or minus 1.2, meaning that some of the people did develop 1 or 1.5 milligram increase in the level of uric acid. This, I think, is the only real concern, that uric acid. So it's good to have a baseline uric acid and try to find out whether the uric acid is going up or whether the patient is developing clinical gout. Except for that, I think the rest of the side effects are all reasonably acceptable. So let us conclude. Bempedoic acid becomes the first ACL inhibitor and first oral non-statin to demonstrate a statistically significant reduction of 4-point MACE events in patients with or who are at high risk of cardiovascular disease with documented statin intolerance and elevated LDL cholesterol. So to conclude, bempedoic acid is an effective alternative to statin intolerant patients based on this clear outcome trial. So in statin intolerant patients, till now we had only ezetimibe, the PCSK9 inhibitor, evolocumab or alirocumab, but prohibitively expensive, the PCSK9 inhibitor. So we had only ezetimibe. Now we have bempedoic acid and the combination of ezetimibe with bempedoic acid, which is currently commercially available. And that does reduce the LDL cholesterol to something like, say, 35%. So well tolerated. Bempedoic acid was well tolerated in a mixed population of primary and secondary prevention patients unable to or unwilling to take statin. Bempedoic acid lowered LDL and hsCRP both by 22%. Remember it that way, 22%. Small increase in the incidence of gout and cholelithiasis. The primary endpoint, the 4-point MACE, cardiovascular mortality, non-fatal MI, non-fatal stroke, and revascularization was reduced significantly, each individually. And the composite endpoint is also reduced. So bempedoic acid has an effective approach to reduce major cardiovascular events in statin intolerant patients. And finally, many of the final analysis of the CLEAR outcome trial has not come yet because this got published in NEJM just 2 weeks ago. Thank you very much. And I will be happy to listen to your comments and any questions. Thank you very much.
Thanks, Dr. George Koshy, for a wonderful presentation, sir. There are a few questions coming up from the delegates. With your permission, can I just read out the few from them?
Please.
Yeah. One of our delegates is asking, sir, that as regular practice, there are many patients with T2DM and hypertension. So, what LDL target should he be going for such patients?
I'm not able to hear properly.
Am I audible now?
Better, please.
Yeah. So one of our delegates is asking that he has got a few patients with T2DM and hypertension. So what LDL target should he be keeping for these patients?
Okay, but what I understand in diabetic people, what should be the LDL target? Okay, that again depends upon the comorbid condition. Is it diabetes alone? What is the age of the patient? How long the patient is having diabetes? Is there any target organ damage or not? Based on that, the LDL target varies. But anyway, in any diabetic patient, the LDL should be at least below 100 milligram. In many of them, it should be below 70 milligram, especially in people with long-standing diabetes and with any evidence of atherosclerotic involvement, subclinical or otherwise. Now, in a post-MI patient, diabetic, you should aim at an LDL at least below 55 milligram. Now, diabetic receiving maximally tolerated statin, LDL below, say, 55 milligram, he is developing a new coronary event within 1 year. Or polyvascular involvement, we can even aim at an LDL less than 50 milligram. That will be my conclusion. And start treatment early. Do not wait too long. That is the new concept. It is not only the quantity of LDL, how long it remains elevated. You should not allow the patient to reach that threshold value of 6,000. Remember that.
Right, sir. So there's one more question. Our delegate is asking if the patient is having elevated LDL-C with moderated statin dose, then what should he do? I mean, either to increase dose of statin or to add bempedoic acid?
Okay, see, based on our previous information, what we were generally doing was you increase the dose of statin. You give high intensity statin. high-intensity statin is that dose of statin that reduces LDL by at least 50%, meaning atorvastatin 40 milligram or 80 milligram or rosuvastatin 20 milligram or 40 milligram. Second add-on drug will be ezetimibe. Third add-on drug can be bempedoic acid. If the patient can afford, you can try PCSK9 inhibitor like evolocumab. But though it is like that, we have this 2021 trial published in Lancet, that is the racing trial, in which people compared 40 milligram simvastatin versus 20 milligram simvastatin with ezetimibe, followed for a period of 7 years, and tried to find out which is a better strategy. And they found that moderate intensity statin with a non-statin drug is an equally good or even better strategy, better tolerated. And the event rates are comparable or even better. So the concept is slowly changing. Statin centric is changing to LDL centric. I will repeat that sentence. After this racing trial, and with the new informations which are accumulating, the concept is changing from statin-centric to LDL-centric. So what is very important is to keep the LDL low. How you achieve that may not be very important. We have more data with statins. Statins came earlier, more trials are there. But that does not mean that statin alone is important. So slowly the concept may change. People may come with the idea of 10 milligram of statin with 10 milligram of ezetimibe with 180 milligram of bempedoic acid. And, we may find out that this may be equal to high-intensity statin or even better than high-intensity statin. But at this point of time, the recommendation is go for high-intensity statin. Second add-on drug is ezetimibe. Third add-on drug is bempedoic acid. In statin-intolerant people, you can give a combination of bempedoic acid with ezetimibe, which is now available. 180 plus 10. Any other comments? Any question?
Yeah, so there's one more question. One of our delegates is asking that what should be an ideal patient profile for bempedoic and ezetimibe combination along with statins?
Now, see, if you cannot reach the LDL goal with statin alone, then you have to add other drugs. So that depends on the LDL threshold which you are considering. For example, based on the ESC guideline or the Lipid Association of India guideline, majority of our patients, you have to bring down the LDL to something like at least 70 milligram or many times 55 milligram or even lower. The maximum LDL reduction possible with the maximum dose of statin is something like 55%. So if your initial LDL, say, is 160 or 180, with high intensity statin, it is ordinarily not possible to bring down the LDL to a value below 70. So you do require add-on treatment. And as I mentioned, first add-on will be ezetimibe, next add-on will be bempedoic acid. So that will be the patient profile. So many of these people require multiple drugs, combination therapy. And the second will be people who do not tolerate statin. Around 15% of the people. And some people refuse to take statin, or maybe they can take only small dose, just 5 milligram atorvastatin, beyond which they develop muscle pain, CPK going up and all that. In such people, again, this is a good combination. And remember, ezetimibe has a very, very safe profile. Ezetimibe is one of the safest drugs. It probably has no major side effects. So ezetimibe with bempedoic acid is a very good combination, producing reasonable reduction in LDL, as much as a moderate intensity statin. But monitor the uric acid I mentioned earlier. and just have a look at the creatinine also. Now, all the three can be given in people in whom the lower LDL goal is required. That will be the patient profile. You are not audible. I think you are muted.
Yeah. Am I audible now, sir? So,
Yeah, you are
in
audible.
line to what you just mentioned, in parallel to your thoughts, my question was, what % of statin intolerance do you observe in your routine practice?
No, I think it partly depends on how you define statin intolerance, That is one point. That is why in the various trials, the values had been different. Overall,
Right.
it may be something like 15%,
Okay.
1.5. But if you ask, a leading question, are you having muscle pain and all that? They will immediately, okay, after you started the other tablet, I am having muscle pain, I am constipated and all that. They will come out with a lot of things if you put a leading question. Maybe something like 15%. But, if you educate the patient properly and if you motivate them, many of them do tolerate mild muscle pain and all.
Right.
And that is the importance of that 6% rule. Always remember that very, very important point. See, 5 milligram atorvastatin reduces LDL by 27%. Just 5 milligram atorvastatin. You increase the dose from 5 milligram to 80 milligram. 16 times. Your LDL reduction becomes 51%, not even double. So small dose statin, most people tolerate. The issue comes when you increase the dose of statin. So I think the future is going to be comparative small dose statin with ezetimibe with bempedoic acid. That I think is going to be the future.
Right.
And I don't know whether ultimately people will come out with 90 milligram bempedoic acid. And then, there is a trend everywhere, hypertension or diabetes, small dose of multiple things, devoid of side effect, ultimately reaching the goal. Only time will tell.
Right. Absolutely, sir. So this brings an end to our questions from our delegate. It was indeed a very lucid presentation from your side, sir. With this, I would request our regional head, Suresh ji, to give a note of thanks to Dr. George, sir.
Yes, sir. Yes, sir. So, respected doctors, a very good evening. I, Suresh Kumar, RBM Citus Medica, is greatly honored and privileged to propose the vote of thanks to our eminent doctor, Dr. George Koshy, sir, as always, for accepting our invitation and helping us organize this scientific program, CLEARTalk, on Bemdac. Thank you very much, doctor. I express my sincere thanks to all the respected delegates for joining this knowledge sharing platform and making it quite interactive. I express my thanks to my superiors, Mr. Mehul sir, Mr. Govind sir, Siddharth ji, Satish ji, and the technical support team for rendering all support needed. With this, once again, my very special thanks to Dr. George sir, George Koshy sir. Thank you, sir. Thank you very much. In future,
So
also.
thank you very much, and thanks to the entire Citus team for coordinating the whole thing. Thank you, Mr. Suresh. Thanks,
you,
everyone, and the entire team, technical support, everyone, and all the delegates. Thank you very much. Good night.
Good night, sir. Thank you, sir.
Good night, sir. Good night. Thank you.